the assessment of patients with weakened instinct of conservation. In general, in nature, any living being has only one instinct, the instinct to exist. But usually we divide it into the instinct of self preservation, which operates at individual level, and the instinct of procreation, which is the concrete manifestation of the instinct of preservation at the level of the entire species. Since no living being can live forever, individuals are compelled to procreate so the species as a whole continues to survive. We are going to focus on the instinct of self preservation, a trait that is built in to the very foundation of each individual. Sometimes this instinct power is eroded by a variety of psychiatric disorders. Individuals end up wanting to abandon life in the majority of the situations because they lost the ability to experience enjoyment. They see life as a string of unending misery. They get no reward out of being alive, therefore, spending time alive makes no sense to them. Sometimes is not just a lack of any enjoyment, but a very painful emotional state. And more rare, a very persistent physical pain. In fact, physical pain alone is not enough to make people want to stop living. It is the limitations that are caused by physical pain impacting their ability to enjoy the state of living which causes wishes to stop existing. The act of suicide can be of a variety of kinds. There is a rational suicide when the patient suffers of a terminal illness that is expected to cause end of life in a matter of weeks or months, not years, in conditions that are very painful or incapacitating or degrading. There is the instrumental suicide when accepting death serve a purpose, some of them good, like saving a first degree relative's life or the life of many other human beings. John Haldane, a major geneticist, is believed to have said, "I would lay down my life for 2 brothers or 8 cousins." He was talking about when suicide makes sense from a strictly evolutionary sense, or the good of the species, which is, of course, rarely the way people think, since they are most of the time not thinking in evolutionary terms when they consider suicide. Some suicides are morally depraved, as, for example, accepting or causing their own death in order to take revenge on a person who they hate. To inflict either legal or social, psychological problems to that person, or cause physical harm or death of the first person who they hate so much. In Romanian, we have a very colorful saying, "Mori cu el de gât," which means you die holding him by the neck, or you die and strangle to death the person who you hate in the same time. Then there is the bulk of suicides we deal in psychiatry, the category caused by losing the ability of enjoying life or experiencing such an intense, painful emotion, sadness, or guilt, that you cannot endure it anymore. And the only way out you can think of achieving that is by ending one's own life. Suicide is the number one cause of professional liability, therefore, you should pay a lot of attention when assessing this tendency. I do not recommend to ever ask the question, "Are you suicidal?" It makes people feel like widgets on an assembly line, and besides, it has very little chance of revealing the most dangerous cases, since those patients will hide these kind of thoughts. I recommend to ask questions in a gradual manner. First, you have to ask if the patient experienced sadness most of the time in the last few weeks. Then ask if they still have the ability to experience enjoyment. If no, then you ask if they feel indifferent whether they live or die. If they confirm, you proceed to asking if they ever in their whole life experienced moments of considering ending their lives. If they say yes to any of these questions, ask them if in those moments there were thoughts of ways in which they could have ended their lives. If they say again yes, ask them what specifically were they thinking of doing. If they had in mind accessible means like pills, jumping off a bridge, walking into the traffic, versus planning to jump in a black hole, uh, then it would be another major red flag. Then you must ask if they were ever close to acting on these plans, like ready to take an overdose, but the plan was interrupted by a visitor. If the thoughts of suicide were recent hours or days, plus there was a realistic, accessible plan, and especially if there was a plan ready to start already on the way that was thwarted by some unexpected random event, you will have to recommend continuing treatment in the hospital. If the patient refuses, 911 should be called. Remember that the clinician does not have the power to admit the patient in the hospital. That is the prerogative of the psychiatrist in the emergency room. But you do have not just the right, but the obligation to prevent loss of life by recommending inpatient treatment. And if the patient refuses, then involuntary inpatient treatment.